oftenly. And since the repeat questions are asked very oftenly, and the important topics, they mostly remain the same. And the questions the questions which are asked every year, they are just asked with small changes here and there. And so the important topics remain the same, and sometimes the whole of the questions, they are repeated as such. So the revision of the previous year questions before the exam, few days before the exams, becomes a must. And so here we are going to do a rapid revision of the previous year questions in the ophthalmology. So let us begin with the first question. And this question is an image-based question which asks that incorrect statement about the given condition. Now, since it is an image-based question, firstly we'll see the image. We can see that this is the pterygium. This is the pterygium. This is a very direct question, pterygium. Now let us look at the options. The first option is simple excision can reduce the recurrence by 90 to 95%. It consists of head, neck, and body. It can be progressive and regressive. And the fourth option is it is due to the elastomeric degeneration of the collagen. So let us take a look at the pterygium and the other options. So pterygium, as we know, it is it is a type of a corneal degeneration. There are main two corneal degenerations which we discuss. One is the pincicula and other is the pterygium. We know that pterygium is a conical or the triangular fibrovascular growth of the congenital tissue, usually present on the nasal side, most of the present on the nasal side, and it happens due to the elastotic degeneration. It happens due to the elastotic degeneration of the corneal epithelium. It can invade up to the cornea. It can invade up to the cornea. It can go up to the Bowman's membrane. It can invade the epithelium, corneal epithelium, and go up to the Bowman's membrane. And it has three parts. It has three parts as cap, or we can say head, neck, and body. It consists of three parts: cap, head, which we also know as head, neck, and body. Yes, it can be progressive and regressive. There are two main type of changes which are present in the pterygium. One are the hyperplastic and other are the degenerative. If the hyperplastic changes are more than degenerative changes, it can lead to its progression. If degenerative changes are more, it can be regressive type, or it can be, it can remain stationary for many years and can change into progressive or regressive type. And it is due to the elastotic degeneration of the collagen. Now, so option B, C, and D are correct. The first option, which says that simple excision can reduce recurrence. Actually, there are two main types of surgeries we do in pterygium. One is the bare sclera technique, in which we remove this fibrovascular growth and do not put any sutures, do not put any autograft. That is the simple excision or the bare sclera technique. In this technique, there is high recurrence. It can recur up to 80%. The option says it can reduce the recurrence, but actually it can reoccur in up to 80% of the cases. The other technique which we use in the surgery of the pterygium is the conjunctival autograft, in which we will remove this fibrovascular growth, and then we'll take a flap of the conjunctiva autograft from the superior part, and then we can suture it, or with the help of sutures, or we can just leave it as such. So this is known as by the name of conjunctival autograft, and it has a recurrence rate of up to 20 to 30%. So the first option, which says that simple excision can reduce its recurrence by 90 to 95%, is a wrong statement, and hence the option to this question. Now we know that there are two main types of the conjunctival degeneration. One is the pincicula, and other is the pterygium. And pincicula, it is a yellow whitish nodule-like formation or degeneration of the conjunctiva, and pterygium is a triangular fibrovascular growth. Now, one thing you should also learn is another surgery for the pterygium is this perfect surgery. This is known by the name of the perfect surgery, and it is perfect surgery stands for pterygium extended removal followed by extended conjunctival transplantation. It is just a modification of the conjunctival autograft surgery in which we just, remove the extended removal of the Tenon's capsule is done so that the recurrence rate decreases to more further ratio. So it is just a modification of the conjunctival autograft surgery known by the name of perfect surgery. And these are the steps we do in the conjunctival autograft. We remove this fibrovascular growth and we take another conjunctival autograft from the superior side mostly and replace it on the lesion side. Okay, and other technique which we can use it by the use of mitomycin. We can also use mitomycin C, which can reduce the formation of the fibrovascular growth and can help to remove or reduce the recurrence of the lesion. The next question is identify the given condition. It is again an image-based question, a direct question which was given to identify the image. Here we can see is on the, we can see on the lens surface, we see small pigment, circle of pigment of the iris over the lens surface. Now this is known by the name of Gaussian ring. This is known by the name of Gaussian ring. Why it happens is it happens in the cases of blunt trauma when the iris tissue gets imprinted on the lens surface. When the iris tissue gets imprinted on the lens surface in the blunt trauma, in the cases of the blunt trauma, this is known by the name of Gaussian ring. Other options given in the questions were KF ring. KF ring, we know that a very common, very, many times learned thing, KF ring is the appearance of a golden brown ring on the corneal periphery, which we've seen in the cases of the Wilson's disease, where it is an image of the KF ring, a golden brown ring on the periphery of the cornea, seen in the Wilson's disease. Next option is the Fleischer ring. Now see, this is the Fleischer ring. What is Fleischer ring? Is the iron deposition or the hemosiderin deposition on the cornea is seen in the cases of keratoconus. It is seen in the cases of keratoconus. Fleischer ring is the deposition of iron or hemosiderin specifically in the cases of keratoconus. KF rings is the deposition of copper on the peripheral or the limbal part of the cornea in cases of Wilson's disease. Next is the Weiss ring. Now Weiss ring is this. This is Weiss ring. Now we can see this is the fundus. Weiss ring is whenever there is posterior vitreous detachment, we can see a ring in the fundus. In the indirect ophthalmic examination is this ring of the vitreous tissue that is known by the name of ring in the cases of posterior vitreous detachment. Now a quick look at, because we added Fleischer ring, so just giving you a few images about the keratoconus. Also the other signs, one we read is the sign that is the Fleischer ring. This sign is known by the name of Rizzuti sign. This is Rizzuti sign. Whenever we shine bright light, a pen torch light from the temporal side to the patient, we can see a conical projection on the nasal side. We can see a conical projection on the nasal side known by the name of Rizzuti sign. Other signs are the Munson sign. Because we know that in keratoconus there is conical shape, the cornea assumes a conical shape. So whenever the patient looks down, there is conical projection of the eyelid. There is conical projection of the lower eyelid due to the conical projection of the cornea. So Munson is the corneal projection of the eyelid. Okay. This keratoconus image, this is the Fleischer ring, this is the Vogt stria. These are the vertical stria which are seen in the keratoconus. Just the diagrammatic, pictorial diagrammatic of the keratoconus changes, Munson sign, topographic signs we know that we can see in the keratoconus. These are the Vogt stria. This red area in the topography shows the thinning of the cornea in the shape, in the area where it has assumed the conical shape, fissure rings, hydrops whenever there is accumulation of the fluid in the corneal, scissoring reflex in the retinoscopy, and Visuti sign whenever we shine the torch of light from the temporal side of the patient looking forward, and we can see a conical projection on the nasal side. So here the answer becomes the osseous ring. Next question is true statement about the KF ring. We read the KF ring here. Now the question about the KF ring is, some options are given. We have to look about the options. One is seen in all patients with neurological involvement, pathognomic for Wilson's disease, resolves with desferrioxamine treatment, seen in all patients with hepatic involvement, and seen in the superior and inferior decimet membrane. So let us start with a quick revision of the KF ring. What is the KF ring is? It is a golden brown ring, usually golden brown. It is, this is not always a golden brown ring. It is usually, the color is due to the illumination, and mostly it is seen golden brown ring because of the type of the illumination we use in our examination. So golden brown ring seen on the periphery of the cornea. It is seen in the decimet membrane of the cornea. When it is seen in Wilson's disease. Wilson's disease. Now we know that Wilson's disease has two types of involvement. One is the neurological involvement and other is the hepatic involvement. Now it has seen that in the patients with neurological Wilson's, 90 to 95% of the patient of neurological Wilson are seen with KF rings. They have the KF rings. While around 50% patients of hepatic Wilson have KF rings. Okay, so 90 to 95% as the question asks all patients, so we can roughly say that approximately 100% or all the patients, and while in hepatic, around 50% of the patients with Wilson have KF rings. So the first option, which says that seen in all patients with neurological involvement, is true. Is it pathognomic for Wilson's disease? Actually, it is seen commonly in Wilson's disease, but it is not pathognomic. Why? Because it can be seen in diseases like cholestatic diseases. It can be seen in diseases of the cholestatic diseases like neonatal cholestatic diseases. So it can be seen in other diseases also. So it is not pathognomic for Wilson's disease. Next is, it resolves with desferrioxamine treatment. Now we know that what happens in Wilson is increase in the copper levels. So how do we treat it? We treat it with penicillamine. We treat it with penicillamine. Now, when we treat it with penicillamine, it can resolve. It can resolve. The KF rings are a reversible type of lesions. They are reversible. It can resolve with penicillamine treatment. Okay. So it is a reversible condition, but it can reoccur. It can reoccur if we stop the treatment. If we stop the treatment, so it can resolve, but it can reoccur, and it resolve usually after 3 to 5 years of continuous treatment. So penicillamine is the drug of choice. Second treatment we use is zinc. Why we use zinc is because it decreases the absorption of the copper. So zinc is used mainly as a type of a maintenance therapy for the KF rings or the Wilson's disease. Penicillamine and then zinc as a type of maintenance therapy. Desferrioxamine is not a chelating agent for the copper or using Wilson's disease. Okay, and the next option is seen in all patients with hepatic involvement. No, discussed already. Next is seen in superior and inferior decimet. Yes, actually, as with this diagram, in this we can say it is present in 360 degrees, but usually it starts in the superior and the inferior part of the cornea, and then it can spread to the whole periphery of the cornea or the limbus. Okay, So it usually starts in the superior and the inferior part of the cornea, and then it can spread towards the whole of the periphery. Okay. So the treatment is penicillamine and zinc. And one question asked in NEET-PG was the levels of ceruloplasmin. So in Wilson's, there will be increase in the copper levels in blood, but there will be decrease in the levels of ceruloplasmin in blood. Decreased ceruloplasmin and increased copper levels. So what will be the answers? What are the true statements? One is the true statement, and we have the fifth. So the answer will be A. The answer becomes is the option number A. Next question is, topical atropine is contraindicated in. So topical atropine, we know that atropine is a type of mydriatic cycloplegic drug. It is used in contraindicated in malignant glaucoma, corneal ulcer, acute congestive glaucoma, acute anterior uveitis. Now, first thing, if we do not know all of the options, we usually know one option is that is acute congestive glaucoma, where we know that atropine is the contraindication. We know that acute congestive glaucoma type of the pupillary block glaucoma, where we use meiosis as a treatment, and we avoid, or the mydriatics are the contraindications. And now, since it is a direct option, we just need 1 to 2 seconds to answer this question. But however, we'll try to read all of the options. But since it is a very direct question, and the answer becomes acute congestive glaucoma, because acute congestive glaucoma, meiosis are the treatment of choice. And why mydriatics are contraindicated? Because the attack of the acute congestive glaucoma occurs in the mid-dilated pupil size. Because it occurs in the mid-dilated pupil size, the acute angle closure occurs. So the mydriatics are a contraindication. Now, other options, corneal ulcer and acute anterior uveitis. So we know that the mydriatics are used as a part of the adjuvant therapy. As a part of the adjuvant therapy, because they can help the patient to get relief of the pain by decreasing the spasm of the ciliary muscles, by decreasing the ciliary spasm, they can help the patient to get relief of pain. So they are used as a type or as a part of the adjuvant therapy in cases of corneal ulcer and acute anterior uveitis. Now the next option comes is the malignant glaucoma. So let us quickly revise about malignant glaucoma, which can be asked as a separate question, because since it is an important topic. So malignant glaucoma, known by the names of ciliary block glaucoma, aqueous misdirection syndrome, and inverse glaucoma. Malignant glaucoma, nothing malignant is there in it. It is only because it is not treated by the conventional therapy, and it can increase rapidly. It can increase rapidly, so it is known by the name of malignant glaucoma. It mostly occurs post-operatively. Mostly it is a post-operative complication. It is a post-operative secondary glaucoma after cataract surgery, but most common surgery associated with the development of malignant glaucoma is trabeculectomy. Trabeculectomy is the most common surgery. It can also occur after cataract surgery. So what is happening is, why it is happening mainly is because of the malrotation of the ciliary body. Whenever there is malrotation of the ciliary body, this is the normal eye, where the ciliary body, they are producing the aqueous, this yellow aqueous, and it is rotating, or it is present only in the anterior segment, produced in the posterior chamber, goes into the anterior chamber and gets dispersed through this area only, not going into the posterior segment where there only is the vitreous present. But what is happening here in the malignant glaucoma is, due to the misdirection of the ciliary body, this aqueous gets collected in the posterior segment. It gets collected in the posterior segment, which then pushes forward the lens. The lens is being pushed forward, and then it will block the angle. Lens is being pushed forward because of the pressure of the aqueous, and it will block the angle. Now, lens is being pushed forward here, so there will be most angle closure, or there will be most shallow angle at the center. So the center, there will be most shallowing of the angle will be of the anterior chamber will be seen. So because of the malrotation, aqueous pockets will collect posteriorly, which will push the lens anteriorly, and there will be shallow anterior chamber. Now, one important thing is how to differentiate between angle closure glaucoma and malignant glaucoma is, in malignant glaucoma, the AC is most shallow in the center, in the central area. While in angle closure glaucoma, it is most shallow in the peripheral parts, It is not the most shallow in the center, but in the peripheral or the paracentral area, while in malignant glaucoma, most shallow in the center of the anterior chamber. Okay, so this is the one important thing. Now, how do we treat? How we are going to treat this malignant glaucoma is either, we can relieve the spasm. We can relieve the spasm of the muscles by the use of hydriatics. So, in the cases of malignant glaucoma, atropine is used as a treatment. Now, in angle closure glaucoma, shallow AC, but atropine contraindicated. Malignant glaucoma, shallow AC, but atropine is the treatment. Atropine is the treatment. Or what we can use is, we can do the PI. We can use the PI. We can relieve the patient of the ciliary spasm, and also PI is also used as a diagnosis of the malignant glaucoma. It is also used as a type or the part of the malignant glaucoma, and also as a part of the treatment of the malignant glaucoma. Next question is, which of the following drugs acts via increasing trabecular meshwork outflow? Now, this is a rapid revision diagram of the outflow of the aqueous. We know that it is formed in the posterior chamber. This is the posterior chamber, anterior chamber, and behind the lens is the posterior segment. Anterior chamber and posterior chamber make the anterior segment. Okay, so it is made in the posterior chamber, goes into the anterior chamber, where either it is absorbed via the trabecular outflow or via the uveoscleral outflow. Trabecular outflow compromises 70 to 80% of the outflow. Uveoscleral contributes to 20 to 30% of the outflow. Okay, so since in glaucoma what is happening is there is more aqueous, so what are the treatment? Either we decrease the production or increase the outflow. We know that we have learned this n number of times. Treatment of the pharmacotherapy of the glaucoma is the either to decrease the production or increase the flow. You can decrease the production via the ABC drugs, alpha agonist, beta blockers, carbonic anhydrase inhibitors. But you can increase the flow, either of the two, either uveoscleral or trabecular meshwork. Uveoscleral prostaglandins. Which type of prostaglandins? F2 alpha. Trabecular meshwork by miotics like pilocarpine, or drugs like Rho kinase inhibitors known by the name of NEET-PG. NEET-PG is the Rho kinase inhibitor which increases the trabecular meshwork outflow. Drug of choice in open-angle glaucoma, prostaglandins. We know that nitarsodil is a newer addition to the glaucoma drugs, which increases or helps in lowering the IOP. It also decreases the production. Nitarsodil's mechanism of action also involves decreasing the production, but the main mechanism stands to be the increasing in the trabecular outflow of the aqueous humor. So the answer to this question becomes nitarsodil, which increases the trabecular meshwork. Also, again, quickly revise the side effects. We know that prostaglandins are contraindicated in any condition which is inflammatory in the patients who have the history of uveitis, who have this history of macular edema. We have to avoid the prostaglandins. Prostaglandins, they can cause hypertrichosis. You can be asked in the question that we can prescribed in the patients of alopecia which can lead to hypertrichosis. We can use it in such cases. Beta blockers, they are associated with the chances of conjunctivitis, and they are avoided in such patients. Okay, it can lead to the causes of the conjunctivitis. So the next question is true regarding primary open angle glaucoma. There are, again, we are given the question. This type of the questions, they are very common in INI, where we are given 2-3 options and we have to choose either the incorrect or the correct statements. So the question states we have to choose the true statements regarding the primary open angle glaucoma. So the first option is it is due to the blockage of trabecular meshwork seen on gonioscopy. Next is or I think it's the first degree relatives, they have more chances of developing steroid-induced glaucoma. Dilatation of the pupil is associated with exacerbation of the intraocular pressure. First degree relatives, they are at 1% risk of primary open angle glaucoma. Visual field defects, they can exist with normal CD ratio. So let us try to understand each of the options. First is due to the blockage of trabecular meshwork. Now, firstly, the question is about the open angle glaucoma. In open angle glaucoma, we do not find anything on gonioscopy. Gonioscopy is used mainly in the diagnosis of the angle closure glaucoma because gonioscopy is normal in open angle glaucoma. There is no blockage in the trabecular meshwork. There is just increase in the resistance of the flow. There is increase in the resistance of flow through the trabecular meshwork, but there is no due to the blockage. And in gonioscopy, we are not going to see any kind of blockage in the primary open angle glaucoma. This stands to be a wrong statement. Next is first degree relatives, they have more chances of developing steroid-induced glaucoma. That is a very, very true statement. Even if you do not know these options, we always, we know that whenever there is such options like first degree relatives or hereditary or the familial options, they in glaucoma or many of the diseases, most of the diseases, they have higher chances of having the same diseases running in the family. So the first degree relatives, they have more chances of developing steroid-induced glaucoma is a true statement. Dilatation of the pupil is associated with increase in IOP. Actually, we are talking about open angle glaucoma, and dilatation of pupil, we know that causes the exacerbation of IOP in the angle closure glaucoma because it can lead to the acute angle closure in the mid-dilated pupil. That is the most characteristic feature of the angle closure. We are given in the question that patient was sitting in a cinema hall and patient developed sudden pain, redness in the eye. What is the diagnosis? Because patient was in the cinema hall in the dark place, there was dilatation of the pupil and patient went into acute angle closure. So it is the pathognomic or very characteristic of the angle closure, but not of the open angle glaucoma. So this stands to be a wrong statement. First degree relatives, they are at 1% risk of primary open angle glaucoma. See, even if you do not know, because most of the times we do not remember the percentages of these types of effects. So whenever there are increased risks, 1% appears to be a very low risk, which can put to the patient of a similar family. So we can, even if we do not know the answer, we can easily rule out because 1 degree, appears to be a very small percentage. Actually, there are two main types of hypothesis, or not just the hypothesis, but the studies which claim. One study claims that there is increase of 3.7 times increase in the first degree relatives to have primary open angle glaucoma, and one Indian study, it claims to be increased risk 10 times increased risk in the first degree relatives. So it is far more than 1%, even if we go by the Indian study. So this is not 1% increase, 10% increase in the risk of the open angle glaucoma in a first degree relative or a familial. So this appears to be a So this appears to be a wrong statement. So they are not at the 1% increased risk, but at least 3.7 or 10% according to one study. So this is a wrong statement. Other is the visual fields defects can exist with normal CD ratio. We know that in with glaucoma, we always read that in glaucoma, the first sign is increase in the cup disc ratio, but that is not always the case. Sometimes visual fields defects, they can appear first, they can exist with normal CD ratio. And one perfect example of this is the presence of wedge defects, which are seen in the red-free filters, that is the wedge defects. So let us start looking at the fundus changes we can see in glaucoma. So firstly, discussing the option given, that is the wedge defect. In this image, that is the red-free filter, you can see a defect. This is the wedge shaped defect which is seen without any involvement in the cup disc ratio. These wedge shaped defects can be seen. So these are the type of visual fields defects. So the answer to this question becomes, the answer will be the true regarding. The first option is wrong. Only the second and the fifth option, they are the correct statement. So the answer to this question will become C. Now, the other fundus changes we can see in glaucoma are, the first is, the most pathognomic, most characteristic is increase in the CD ratio. That is we know that it is the oval cupping. That is the oval cupping. The shape of the cup, the increase in the cup is the in the oval shape. So there is increase in CD ratio, which is oval. In number, normal CD ratio is 0.3. More than 0.5, there is glaucoma suspect. Whenever it is increasing more than 0.7, it is straightforward glaucomatous cupping. So this is the normal cupping, and there is increase in the cup disc ratio. So whenever there is increase in cup disc ratio, we know that this is the optic cup and this is the normal healthy tissue. This is the normal healthy neural tissue. Whenever there is increase in the cup, so this tissue will decrease. So there will be thinning of the neuroretinal rim. Thinning of the neuroretinal rim will happen. So there is increase in CD ratio and thinning of the neural retinal rim. And other things we can see here, we can see these splinter hemorrhages. We can see this peripapillary around the optic nerve head. These are the peripapillary hemorrhages or the splinter hemorrhages. These are not as such pathognomic, can be seen in other diseases also, but seen commonly in the glaucomatous fundus. This is the bearing of the vessels. What is happening in glaucoma? We know that there is loss of tissue. So these horizontal vessels, and they appear to be roaming freely, because in normal tissue they are supported behind by a normal healthy tissue. Whenever there is loss of healthy tissue, these vessels, they appear to roam freely without the healthy tissue behind them. So this is known by the name of bearing of vessels. This is known by the name of bearing of the vessels, mostly seen in the horizontal vessels running from the optic head. Now this is a bayoneting sign. This is bayoneting sign, sharp angulation at the margin of the optic cup, at the margin of the optic disc, sharp angulation. Why this sharp angulation is happening? Because of the loss of tissue. There is loss of tissue. So there is, whenever there is loss of tissue, there is deepening of the cup. The cup has become deep. So whenever the vessels, they are originating, they will take, because this, this cup has become a loss of shallowing. It has become deep. So whenever the vessels, they will come out of it, they will take a sharp bend because of its increased curvature, because there is loss of tissue. It has become deep. So the vessels, they will take, whenever they will come out of it, will take a sharp bend at the margin. They will take a sharp bend at the margin, which is known by the name of bayoneting sign. Known by the name of bayoneting sign. There is angulation of the vessels, or the double angulation of the vessels, seen at the margin of the optic disc. This is the presence of the collateral vessels. This is the presence of the collateral vessels, which can be seen on the optic disc. This is the laminar dot. If you can appreciate, there are presence of small black dots which are present. These are the fenestration seen by the laminar dot sign. Okay. So these are some of the fundus signs seen in the glaucoma. Next is, which of the following is seen in acute angle closure glaucoma? Which of the following is seen in acute angle closure? Hutchinson triad, Gotcher triad, Bogged triad, Virchow triad. So these are the triad we are asked seen in angle closure glaucoma. We know that Virchow triad, Hutchinson triad, we have studied in, we study them in pathology, in medicine. Hutchinson triad is seen in congenital syphilis. Virchow triads are seen in coagulopathies. Gotcher triad, so I don't think that exists. I haven't studied for Gotcher triad. Bogged triad seen in angle closure glaucoma. Bogged stria, they are seen in, keratoconus, and bogged triad seen in acute angle closure glaucoma. Now, what this bogged stria stands for? What is happening in acute angle closure glaucoma is, due to the ischemia, what is happening is, due to the ischemia, there is, presence of anterior subcapsular opacities. There are presence of anterior subcapsular opacities known by the name of pneumococlex. Due to the ischemia. Other things happening due to ischemia is this iris dystrophy. Iris atrophy is present because of the ischemia. There is loss of pigment from the iris tissue causing iris atrophy. Iris atrophy. And the third sign which is included in the Bogged stria is mid-dilated or poorly dilated, not poorly dilated, mid-dilated pupil with irregular margins. It is a mid-dilated pupil with irregular margins. With irregular margins is the third step in the, or the third part of the Bogged stria. So the Bogged stria include, because of the ischemia, there is presence of the opacity in the anterior subcapsular part of the lens, pneumococlex. Next is, because of the ischemia, there is loss of the iris tissue causing iris atrophy, and there is a mid-dilated pupil, irregularly mid-dilated pupil. These are the three parts of the Bogged triad seen in acute closure glaucoma. Okay, or sorry, angle closure glaucoma. Next question is, how to differentiate the causes of a dilated pupil? Okay, causes of a dilated pupil. So here we are talking about is anisocoria. So quickly revise anisocoria. So let us quickly revise anisocoria. Now, what is anisocoria is, whenever there is difference of more than 0.4 size in both pupils. Both pupil size, there is difference of 0.4. This is anisocoria. Anisocoria can be, it can be pathological. It can be physiological. It is not always pathological. It can be physiological also. Whenever there is physiological anisocoria, it means the difference between two people is more than 0.4, but it is not associated with any disease. Why? When it happens is, so the anisocoria in physiological condition remains same in both dark and light. It remains both same in dark and light condition. Okay. But in pathological, this is not the case scenario. In pathological, either it can increase in dark or it can increase in light. So where here we have two conditions, either increasing in dark or increasing in light. Okay, now whenever it is increasing in light, first we talk about whenever it is increasing in dark. No, now we know that whenever we go in dark, this is the normal pupil. When we went into the dark, what will happen is it will dilate. In the dark, the pupils will dilate. Now, an isochoria is there is difference of pupillary size. So it means the normal responses in dark is the dilatation of the pupil. An isochoria is happening, it means one of the pupil is not able to dilate. So there is small pupil is the abnormal pupil. Now we know that whenever there is an isochoria which increases in dark, in such scenario, the smaller pupil is the abnormal pupil. Similarly, when the anisocoria is more in light, what is happening is whenever the patient enters the light conditions, the normal response is constriction of the pupil. Anisocoria, it means there is difference in the size. So the normal response is hampered in which of the pupil? The dilated pupil. So here the larger pupil is the abnormal pupil. So here the larger pupil is the abnormal pupil. So this is how we know that which type of or the which pupil is abnormal in which conditions. Now how to approach the patients of anisocoria? How to approach the patients of anisocoria? If it increases in dark, whenever there is increases in dark, it means the pupil, the abnormal pupil is smaller in size. Abnormal pupil is smaller. It happens in the cases of, this is seen in the cases of corner. See, the normal response should be dilatation. We know that the sympathetic system causes the dilatation of the pupil. It means there is any problem in the sympathetic system. There is problem in the sympathetic supply, and the sympathetic supply disease is seen where we see the miotic pupil due to the sympathetic supply is the Horner syndrome or the Horner disease. So here we have the diagnosis as the Horner syndrome. Whenever the anisocoria increases in light, it can have different abnormalities. First thing is the abnormal pupil is the larger one. The abnormal pupil is the larger one. Different causes of this can be trauma. It can be due to trauma, that is a traumatic mydriasis. Okay. It can be due to the third nerve palsy. It can be due to the third nerve palsy. It can be due to AD stonic pupil. These are some of the causes of the